Today, our topic of discussion in pediatrics is about gastroenterology, and in this lecture, we are going to cover different signs and symptoms which occur in gastroenterology in pediatrics, and we will talk about certain conditions related to those symptoms and signs. Uh, Now, you can say we can start with history, okay, and examination uh, for GIT, okay. So, like to start with, whenever the children they have any gastrointestinal disorder, how they present, that's very important. And how they present is like maybe there can be vomiting, maybe there can be abdominal pain, maybe there can be diarrhea, um, which are very common. So you can say uh, vomiting, um, abdominal pain, and diarrhea. Like these are the common type of presentations, okay, or the complaints. Um, Now, talking about all these three things, now vomiting can be simply due to a very common condition like gastroenteritis or GERD, like gastroesophageal reflux disease, or like in which they do vomit, or it could be something serious like intussusception or like GIT obstruction. Same thing with abdominal pain and same thing with diarrhea. So, and as you know, like I took the name of gastroenteritis, that gastroenteritis is very, very, very common, and especially in the developing countries, it is so common. Like many children, they die less than 5 years of age. They die every year just due to gastroenteritis. So, so of course, like we are going to cover all these conditions, okay? And we will start about from like talking about the history taking, the examination, and then we will talk about this thing. So, how we define vomiting, by the way? Vomiting is the forceful expulsion of stomach content from the mouth. Okay. So to start, before starting, you must know what is vomiting and what is, you can say, regurgitation. Okay. So vomiting, as I told you, it is forceful expulsion of the gastric content from the mouth, and regurgitation is simply when there is some partially digested food which comes from the stomach to the mouth. Okay. So these two are different things, right? So uh, simply, whenever we talk about taking the history in these patients, you have to inquire about all these things. And I already talk about like how we take the history of vomiting. We ask like how much, what is the color, what is the consistency. Either it's after the feed, and uh, either it's projectile, or either like it's bloody and things like this. And same thing, either it's associated with other signs and symptoms. And same thing, we will ask about the abdominal pain, and same thing, we will inquire things about diarrhea. Okay. So in the history, basically what you should look for is red flags. Red flags means what? Anything which basically, if they are present, so it shows some serious type of condition. For example, um, bilious vomiting, like bilious or bloody, emesis. Emesis is vomiting again, right? Like bilious is like bile stain, which is greenish in color. Uh, Other thing is projectile vomiting. Okay. So when these things are present, of course, like they are the red flags, like something serious is the underlying condition. Or the child have abdominal distension and tenderness, as well as if the child is having high grade fever, okay, or any signs of dehydration. Okay, a sign of dehydration is very, very important in gastroenterology. uh, and remember that uh, if you will talk about examination, in examination again, uh, you will look for um, all these things, the red flags. So always, uh, you can say, pay attention on the clinical status of dehydration. Okay. If the baby is dehydrated, if it means like the thing is serious, or like the children can die. So now we will discuss like many of the conditions which are related to these things. And for example, whenever it comes to vomiting, okay, um, I will show you one very good um, type of, okay, again, now different books, they classify vomiting under different, what you can say, headlines, okay, or you can say headings. Why? For example, here they are given like what are the causes in infants, what are the causes in preschool, what are the causes in school age and adolescents, right? um, Now one of the thing, you can also classify these things. For example, what are the causes of non-bilous vomiting and what are the causes of mm, bilous vomiting, right? So now, if you can see over here, see in the infants, gastroesophageal reflux is the most common one, right? So what is this gastroesophageal reflux is? Okay, guys, in this lecture, maybe like remember, lectures are just to make the things easy. So maybe you will think like I did not discuss much of the topics, but when you will open the book, you will find like I have talked about all these things, and whatever I'll be talking about, you will find the same things in the books. So um, like maybe in this 1 hour lecture, I don't know, like it will be 1 hour more than that or less than that, but in this lecture, which is around 1 hour, you can say I will be talking about many of the conditions, right? So uh, GERD or gastroesophageal reflux disease, uh, see, when we take the history, basically these are the babies. um, this is the condition which is extremely common in infancy, okay. um, so what happened, basically the vomiting in this case comes, typically comes after feeding. And remember, it is non-bilous, and uh, it's not bloody, okay. Bilous is simply bile stained, okay. So simply when there is some obstruction in the GIT, which is you can say after the second part of duodenum where the bile duct is opening, before after that, whenever there is an obstruction, so of course there will be bile stain vomiting. So GERD is simply it's a regurgitation type of condition in which um, uh, after feeding, what happens, like they had vomiting, or it's not a regurg, sorry, they had vomiting soon after feeding, okay. Now, remember, like that vomiting is not of very big quantity, rather it's a very small quantity. Okay, most of the time less than 30 milliliter. So the thing is, for example, most of these babies who have GERD, they are basically completely normal. Okay, they don't have any signs or symptoms. What are the signs and symptoms we look in the pediatric patients? uh, for example, we see either, again, the growth chart thing, we see the growth chart. If the child is growing well, if he's putting on the weight well, if he's not irritable, and if we don't have any other signs or symptoms, uh, we don't get worried about this condition. So simply you must look for the weight gain. You must ask in the history, like if the child is irritable, any sleep disturbances. For example, if while sleeping they are choking or they are coughing or they are wheezing. Of course, if the child is big, like a school going child, uh, or adolescent. So see, like here again, like GERD is not just the cause of vomiting in this age group, rather in this age group and this age group as well. Okay, so we always look for these things. So simply when the child have GERD, and um, the diagnosis is simply like the history. The mother will tell you the vomiting comes right after feeding, and it is non-bilous. It doesn't contain blood, small volume, and the child is growing well. Basically, we don't need any investigations. Or remember this thing, that GERD is basically a clinical diagnosis. Okay, so I think like whatever the points will be there, I should keep on adding on this slide, okay, so that when you will um, like read this topic from any book, like it will be in front of you, okay. So GERD is uh, usually a clinical diagnosis, right? So it doesn't mean like we never go for investigations. For example, if the GERD is creating some problem with, for example, the weight put on, or the baby is not thriving well, then of course we go for investigations. So, for example, to rule out motility disorders, you can see do GIT tract, gastrointestinal tract radiography. Okay, as well as you can say you can go for pH monitoring, uh, monitoring. Okay, like in the esophagus, it is called as esophageal pH monitoring, or you can go for upper endoscopy. Okay, or biopsy, right? While doing endoscopy, of course, you can take biopsy as well. So simply, uh, we don't need these one until the child is not showing any signs and symptoms. But for example, if the child is having bilious vomiting, GIT tract bleeding, forceful vomiting, fever, lethargy, hepatosplenomegaly, seizures, or anything, abdominal tenderness, like whatever the things I told you, of course, you need to investigate them more. So simply, guys, anyone who is diagnosed with just one gastroesophageal reflux disease, we simply tell the mothers, to for some conservative management, like um, one of the conservative management is we tell them that feed them in smaller portions, okay, and always elevate the head, and after feeding, always put the child upright, until there's a burp. One of the thing which we can tell the mothers is simply they can make the feeds a little thick, and there are thickening things you can say available in the market, which they can use. Okay, um, like one of the thing is Gaviscon as well, or simply like if they are bottle feeding, so make them feed a little thick. So that what you can say can fix the problem as well. Sometimes changing the formula milk to amino acid based formulas fix this problem. Sometimes in the breastfeeding infants, if the mother will exclude milk and egg from her diet, the things become better. And if the thing cannot be managed conservatively, then we go for medical management. And medical management, again, it is same like adults. We put them on H2 receptor blockers like ranitidine, or you can say proton pump inhibitors like omeprazole and stuff like this. Some of the drugs, by the way, domperidone and metoclopropamide, these are the drugs which improves GIT motility. Okay, so uh, not use much, like I'm telling you, like for example, what you can say, some of the children where this problem is not going away, so then we can use that, or we can go for the surgery, like um, in surgery when you will study something called as Nissen fundoplication. Okay, so Nissen fundoplication. So what they do, like simply I can show you over here. Bing is my good friend these days, so Nissen fundoplication. I will show you how they do this one. Simply see um, this one. This one you can see over here. So what they do, like simply they make extra sleeve, and see they make this lower esophageal sphincter, you can say they reinforce that. Okay, so they just tight the space so that the food should not regurgitate back. Okay, so this is called as Nissen fundoplication, so this can be used. So this is one of the thing. Rest you can see over here. Feeding problems can be there, and now infections, as like in gastroenteritis, which is the most common cause of vomiting. Okay, gastroenteritis for sure can give what you can say vomiting, and the things, like I don't think so we have to discuss this gastroenteritis more, because uh, uh, the gastroenteritis you will come across at many places. Simply it means like there is inflammation of the like the stomach as well as the intestines, and of course they present with vomiting, diarrhea, fever, anorexia, abdominal cramps and stuff like this. And um, most of the time it is bacterial or parasitic agents in children. Uh, Now, of course, like whenever the children uh, is presenting with uh, what you can say fever, so it's a red flag. So you must think about gastroenteritis. Uh, in an examination, what is the important thing to look for is simply look for if the patient is dehydrated or not, right? So investigations like again gastroenteritis most of the time is diagnosed clinically. A clear-cut history can be found, okay, with uh, someone who had a recent infectious contact with anyone or someone who have consumed something, okay. So within 24 to 48 hours, you will found that clue, like within the last 48 to 24 hours, for 24 to 48 hours, right? So if you want to go for investigations, you know what investigations you can do. You will be doing stool analysis. Okay, so you can say in gastroenteritis, of course, enteritis. What is the thing? If you are going for investigation, so stool examination can be done. Okay, in these patients. Okay, as well as CBC, of course, can be done, or ESR, CRP can be done as well. They are the normal tests. Okay, so of course, like in stool examination, they can found the bacterial or parasite etiology. Okay, so this thing is very 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 common. If it is viral gastroenteritis, you know it is self-limiting, but if it is bacterial gastroenteritis, guys, remember, uh, depending on the organism, it could be bloody, it could be non-bloody. Okay. Uh, in the children, remember one of the most common type of virus which can cause gastroenteritis is rotavirus. Rotavirus is the most common one. Okay, the other viruses can cause also cause like norovirus or enteric virus, but rotavirus is the most common one. And whenever it is bacterial, so salmonella, shigella, campylobacter, e coli, yersinia, and as you know, what are the causes of bloody diarrhea? It could be e coli, it could be campylobacter infections like this. So they can cause bloody diarrhea. Okay, so now most of these children, you know, who have gastroenteritis, you will found that like they are attending the daycares or they have contact with the sick contacts, or they have a history of travel or some not properly cooked food, or maybe they are taking some antibiotics. So remember, if it is bacterial, we will go for the antibiotics. Okay, and if it is viral, of course, like it is self-limited. But what you have to take care, remember, the most important thing in this one is dehydration status. Okay, dehydration status is very 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 common thing you have to look for because they can kill the patient. Okay, and now guys, you know, one of the important thing to mention over here is simply what um, um, the most common viral cause is rotavirus. You know, nowadays all the children, they get a vaccination for rotavirus. Okay, so that's why the incident is decreasing. Rest, you know, vomiting can be caused in whooping cough. You know, again, it's a respiratory tract infection, respiratory tract otitis media. UTIs can give vomiting, meningitis can give vomiting, and now some interesting condition. For example, dietary protein intolerance. Okay, so now when the children they have uh, a protein intolerance. Okay, what happens is simply um, in this one is what happens like one thing is called as cow milk protein intolerance. So what happens is like when they consume the milk, you know, so they cannot tolerate that protein, so they keep on vomiting, right? So in that case, you know, the only management is to remove that, like stop taking that protein. Okay. Now, you know, there's some serious causes of vomiting, intestinal obstruction like pyloric stenosis, right? So now, pyloric stenosis for me is a very interesting type of condition. Why? Because what happens in pyloric stenosis? There is hypertrophy of the pyloric muscle. Okay. Again, I can take the help of Bing and I can show you how it looks like. Um, Pyloric stenosis. Okay, I will show you here. Very interesting type of condition. So see, what happens is simply, guys, you can see like this is the normal anatomy. So in children, what happened, like their pylorus is enlarged, so the things cannot pass beyond this thing. Okay, so whatever they eat, it stays in the stomach. So now, the important thing to remember in this one, pyloric stenosis patients, they present around 2 to 7 weeks of age. Okay, and it is more common in boys, 4 times more common in boys than girls. Okay, and they are mostly the first borns. Okay, and some of them, they have a family history as well. Now the interesting thing about this one is what they have: vomiting, and the vomiting is after the feed, and the vomiting is projectile. It is forceful type of vomiting. When the child vomit, it doesn't soil its clothes, rather the vomit goes and fell, because it's forceful, so it goes a little far. Okay, so that's what is called as projectile vomiting. So remember this thing, guys, it causes projectile vomiting. Now, because the child is completely healthy, so after vomiting, what happens, the child, they become hungry again, they started crying for the feed again. Okay, so most of these children, of course, because they have forceful vomiting again and again, so the parents, they bring them after within 2 to 3 days. But if the condition is prolonged, of course, the child may be having weight loss. And one of the things to mention over here is, because they lose a lot of um, gastric fluid, which is full of acid, so they can go into, they lose HCl. Okay, so they can go into hypochloremic metabolic alkalosis. Hypochloremic metabolic alkalosis. And they may have hyponatremia as well as hypokalemia because of vomiting. Okay, now the interesting thing, the only problem is what I show you over here, like their pylorus is enlarged, right? Now, I will show you something. Um, wait. Okay, wait. I will show you how they treat it. Um, Stenosis. Okay. So, um, now, guys, the important thing over here is what they do. Okay, what they do, I will discuss later. But I was talking about the diagnosis. Okay, so when the baby come, always talk about or see like either the baby is dehydrated or not. So simply, if the baby is dehydrated, so treat that. If they have alkalosis or hypochloremic metabolic alkalosis, treat that. If they have any electrolyte problems, treat that. How we can diagnose? Simply ultrasound can be done, ABGs can be done. Okay, because they have, of course, that their metabolic alkalosis. So now the like after correcting their fluid balance, the only treatment is a very very short type of you can say surgery, which is called as pyloro pyloromyotomy. Okay, so what they do, see, yes, this is a good one. It is done by a small type of incision, and what they do, they simply wait, do this thing. They just make a small cut. Okay, on the pylorus from outside. Wait, I will show you a better one if I can found over here, or you can see this one. Okay, what they do, like they just this is the endoscopic technique, of course. Um, this just like put a small cuts. Okay, see, this is like the hypertrophy, so they must take do a small cuts. So like they simply relax the muscles around the pylorus, and they just open like that narrowing. Okay, so very simple procedure, and nowadays it is done laparoscopically. So very important points to remember about this one, guys, are which one? It is more common in boys, um, mostly the firstborn child of the family. And one very interesting thing which I forget to tell you is, sometimes, not always, when you will examine the baby, you can see the signs of gastric peristalsis. There are small palpable abdominal mass which you can see on the tummy. Basically, that is pylorus, hypertrophic pylorus, right? So the diagnosis is done by ultrasonography, and the treatment is simply treat the dehydration and do pyloromyotomy. Okay, do pyloromyotomy in these cases, in these patients. So this thing now, other than this, you can see there could be atresia, duodenal atresia. Now, this is something, a serious condition. See, when they have duodenal atresia, so now this is something um, like this is a surgery topic, but I will just show you what it is. So basically, guys, these are the babies who like they have atresia of the duodenum. Now, like of course, like some of the time it is the one and the alone thing. Sometimes it is a part of some other congenital disorders, right? So what we can do, one very 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 important thing to remember about this condition is what whenever there is duodenal atresia, we go for, okay, now when see the duodenal atresia is there, of course nothing will pass from here, so they present with vomiting. So when they have vomiting, remember guys, it's the one of the cause which can give bilious vomiting, bile stained vomiting, and the patient present with abdominal distension. The patient can present with jaundice. It is most commonly present in the babies who have Down syndrome. And what kind of metabolic abnormality they have? The same one: hypochloremic, hypokalemic, metabolic alkalosis. Now, simply whenever we are suspecting that someone have GIT obstruction, we go for X-ray. And when we do X-ray, guys, we see double bubble sign, which you can see over here. Double bubble sign. Okay. So simply this is called as what? Double bubble sign. Okay. So see all the double bubble signs you can see over here. So simply this one is called as the double bubble sign. Okay. So this is air fluid level which we can see over here. So now guys, whenever like they have duodenal atresia, simply they show double bubble sign. It is bilious type of vomiting, and um, distension, abdominal distension will be there. Now guys, of course this one can only be treated by surgery. Okay, I will show you something. What are the causes of bilious vomiting? Pylorus, duodenal atresia, um, intestinal obstruction like malrotation, volvulus, okay, or Hirschsprung disease, okay, or strangulated hernia. So see what these things are doing. They are causing GIT obstruction. So remember, all these causes will present with what? Bilious vomiting, abdominal distension, bilious vomiting with abdominal distension, and of course, like these children, they cannot pass the stool because their GIT is obstructed. So simply we go for what? We go for X-ray. Okay, and if I will show you the X-ray of any one of these things, okay, uh, X-ray volvulus. So see, air fluid level. Okay, if you had done in radiology, so either this one is like in volvulus, okay, or for example someone with malrotation. So simply surgeons, they can see air fluid level in this one. So whatever is the case, guys, the surgeons, they can diagnose easily just by X-ray like there is some GIT obstruction. So we can simply go for abdominal X-ray series, okay, and we can diagnose like there is a GIT obstruction, and the treatment is simply surgical. Okay, all these conditions can be treated surgically. Okay, Hirschsprung disease is a kind of disease. What happened basically? There is you can say a small portion of the GIT is there, basically, which are aganglionic, like there is no neurons there. So basically there is no peristalsis over there. So that's why it can lead to GIT obstruction. Okay, so this thing, And of course, like any inborn error of metabolism can give vomiting. Congenital adrenal hyperplasia, I told you, we already discussed this thing, they also present with vomiting. Renal failure can present with vomiting as well. Okay. So of course, like if there is inborn error of metabolism, so you will find like they have poor feeding, failure to thrive, jaundice, hepatosplenomegaly, things like this. And we go for electrolytes, we go for ABGs, and we go for LFTs, we go for blood urea nitrogen and all this stuff. Okay, just to diagnose what is the condition which is causing this thing. Yeah, and one of the thing which is not written over here, sepsis can cause vomiting as well. Okay, sepsis can cause vomiting as well. Now, if you will see, like in preschool children, again, the things are quite easy. Gastroenteritis we discussed, infections like respiratory tract, UTI, meningitis, whooping cough, all of they can cause. Appendicitis, you will study in surgery, it can cause. Intestinal obstruction, same thing. Okay, yes, I will discuss intersusception now. So intersusception, malrotation, valvulus, adhesions, foreign body, raised intracranial pressure. Now, raised intracranial pressure, whenever there is vomiting due to that, what happens is basically the vomiting comes early in the morning, and it also gives projectile vomiting. But remember, in this one, the vomiting is associated after feeding, like it comes right after feeding. In this one, the vomiting come um, early in the morning, right? Celiac disease, like it's a malabsorptive type of condition. Renal failure, inborn error of metabolism, and torsion of the testes. I will discuss this condition. And in school age or adolescency, uh, almost the adult causes like gastroenteritis, appendicitis, migraine, raised intracranial pressure, celiac disease, renal failure, diabetic ketoacidosis, all these things, and pregnancy even, right? So of course the causes will change. Now, guys, the important thing, there is one thing called as here, see, cyclical vomiting syndrome. What is this one? Um, I will tell you, cyclical vomiting is when there is at least three self-limiting episodes of vomiting which last for 12 hours, and there should be 7 days between the episodes, and you cannot find any cause for the vomiting. We call it as cyclical vomiting syndrome. At least three self-limiting episodes of vomiting lasting at least 12 hours, 7 days between those episodes, and there is no organic cause of vomiting. This is our diagnosis of exclusion. Okay, so of course, like if there will be appendicitis, of course there will be signs and symptoms of appendicitis, whatever is the age group is. One of the thing is tracheoesophageal fistula as well, they can also give vomiting. So simply, like, these are all the causes of vomiting, right? um, uh, in the babies. Now, to talk about more, I want to talk about intersusception, right? So, what happened is in the babies, who have intersusception, it's a very interesting type of condition, guys. Now, talking about intersusception, um, what happens is basically these are the children. um, what happened, like there is telescoping of their intestine. You can see like the telescoping of the intestine, okay, over here. For example, I will show you intersusception here. Intersusception, uh, see what is happening over here, guys. If you will see over here, see his this is the most common site as well. See the um, ileum is the normal is like this, and see this one have invaginated or telescoped inside, right? So simply there is invagination of the proximal bowel into the distal segment, okay, and this is the most common site, like the ileum went into the cecum, okay, through the ileocecal valve. Now, this is a very common cause of intestinal obstruction in infants. Okay, it can occur in any age, but most commonly it present around until 2 years of age. Now, guys, the most important thing about this condition. So, see, they are showing you the telescoping here. Okay. So, simply, um, what happens, like, if we see now the blood supply is the segment which is telescoped inside. Of course, the blood supply of that can be compromised, and due to that blood supply compromise, there could be necrosis, there could be perforation, there could be anything. So that's why, it's a kind of emergency. Of course, it will cause what you can say GIT obstruction, right? So now, how the babies present, they present with severe type of pain, and they become pale, and uh, you can say the child while crying they draw up their legs. Okay, so you can say again I can show you over here how they present. Okay, yes, very good diagram again about intussusception. You can see over here. So see, this is the telescoping, or see, all these things can be necrosed, right? So what I wanted to talk about is crying, like how they look like when they cry, so when they cry, they brought their legs up towards the tummy. Okay. So the child cried too much, guys, that they become lethargic. Okay, they started vomiting. They refused to drink anything. When we will palpate their abdomen, maybe you can find a sausage-shaped mass, but in the late findings, maybe there could be bloody type of stools. We call it as red currant jelly stools. Okay, the stools are look like you can see over here. See, this is the radiography of the intussusception, but I will show you. They have red. It's a late finding, by the way. They have red currant jelly stool. Their stool become like this. Okay, so simply they are blood stained mucus containing stools. It is called as red currant jelly stool. Now, what happened whenever we have a patient like this, who have intussusception? So we quickly go for what you can say investigation. We can do abdominal X-ray. Okay, so see, abdominal X-ray demonstrating an intussusception. See the arrowhead. Okay, uh, in this case. So of course we put them on IV fluid. You can see this baby. They put cannulas. We can go for abdominal ultrasound. I show you the that radiography. Okay, how it looks like. So you can see uh, X-ray finding or ultrasound finding. So ultrasound finding, you can see intussusception. Okay, so see, here it looks like. Okay, it is the ultrasonography of the intussusception. So simply we can go for ultrasonography. Okay, quickly in these patients, and once you have diagnosed this patient, uh, we or the radiologist or the pediatrician, what they are going to, they have to reduce it. So one of the way of reducing is what, they give air through the rectum. Okay, and when there is the air reach here, so due to air pressure, it can be reduced. Now, this procedure is unsuccessful sometimes. So if it is unsuccessful, then we go for surgery, and surgically they reduce this thing, or of course, like we can give some hydrostatic pressure as well. So simply, so by in surgery, they remove this thing. They see like if the tissue is necrosed or not, and simply by this way they are going to reduce this. So this is like about intussusception. So um, I think like we had done all the causes, or what, like discussed all the things like which are new for you about what you can say vomiting, right? um, so guys, like of course I told you the treatment of many things, right? But for example, um, I'm including this thing as well. Like this is a red flag thing, see, I told you that bile stain vomiting, intestinal obstruction, hematemesis, esophagitis, peptic ulceration, nasal bleed, projectile vomiting, pyloric stenosis. So very helpful thing you can say, right? So simply I told you the treatment of the things which we can encounter, okay. And if you will remember it this way, I think the things will become easy for you guys, okay. The things are not hard if you will remember in this way about vomiting. And of course, when you are going to study it from the books, the things will become easy as well. One of the things, which I already teach you is infantile colic, in the common problems in pediatrics. So that is about infantile colic. We already talk about this thing. Okay, guys, now one of the thing is, acute abdominal pain. I told you this thing, the three things, vomiting, abdominal pain, and diarrhea. These are the three common findings. So if I will talk about acute abdominal pain, now see, abdominal pain is so common symptom, which you can encounter anytime in any specialty, okay. And in surgery you are going to study a topic called as acute abdomen. And acute abdomen, simply the abdomen, we see like either there is any tenderness or not. I remember like most of the causes of acute abdomen are basically surgical, okay, the serious one I'm saying. And most of the acute abdominal causes, when it is medical, just few of them are serious. For example, I will tell you, acute abdominal pain can be in appendicitis, right? Acute abdominal pain can come in intussusception. Acute abdominal pain can come in inguinal hernia, like of course the strangulated one, or peritonitis, right? So all these things, are basically the surgical causes. Uh, now, acute abdominal pain, one of the cause of acute abdominal pain in children is what you can say, um, abdominal migraine, okay, abdominal migraine. And um, the important thing about acute abdominal pain is simply whenever any child presents with acute abdominal pain, we simply see either the baby, as you can say, they have any, you can say, organic type of condition or a non-organic type of condition, right? So I will tell you now this topic from a different point of view. Any baby who is presenting with acute abdominal pain, okay, so in history, we take history. So whenever we take the history of pain, we go like sort sara, location, site, onset, radiation, severity, aggravating factors, relieving factors, associated symptoms like nausea, vomiting, diarrhea, fever, and then we go for the abdominal like examination, right? And then we had of course some differential diagnosis. Now abdomen is so big that a lot of structures are there. So when it is about the abdominal pain, think about what are the things. See, GIT is all in the abdomen. So see, these all causes are um, GIT causes, right? Peritonitis. Okay. So these all problems are related to GIT. For example, constipation can give abdominal pain. For example, ulcers can give abdominal pain. For example, lactose intolerance can give abdominal pain. Then see, liver or hepatobiliary system is there. So cholecystitis can give abdominal pain. Pancreatitis can give abdominal pain. Okay. Now, genitourinary system is there. So a UTI can give abdominal pain, or a renal stone can give abdominal pain, as well as you can say many causes like ovarian torsion can give abdominal pain. Now, abdominal pain can be, you can say, due to some systemic conditions, for example, like diabetic ketoacidosis can give abdominal pain. So, abdominal pain is a very, you can say, wide type of topic, right? Now, of course, like, all these are surgical topics, and you will be studying, peritonitis or inguinal hernia, intussusception in surgery, right? Or appendicitis in surgery. So, like, all these are mostly surgical causes. But if we will talk about the chronic abdominal pain, okay, that the interesting thing, and abdominal pain, okay. Now, chronic abdominal pain is um, not so common, but you can say um, it is present in many kids, right? So, any child who have chronic abdominal pain, basically, you can say, it is present in 10% of school-going children, okay? School-going children. And one of the things to tell you over here is females are more affected than males. Now, whenever the child they present with abdominal pain, what we look for is simply either it seems like a organic cause, okay, or it is a functional abdominal pain, okay, functional abdominal pain. For example, I will tell you now why I'm talking about this one, because 10% of the time, or you can say less than 10% of the time, basically, it is due to organic causes, and more than 90% of the chances, you can say, it is without any cause, or it is um, functional abdominal pain. For example, whenever it is organic causes, it could be a constipation, it could be inflammatory bowel disease, it could be pancreatitis, it could be celiac disease. But functional abdominal pain is more than 90% of the time. Now, the important thing, we say that someone have functional abdominal pain when on history, okay, you do not found any alarming signs, okay, symptoms in history, or on examination you do not found any signs, okay. So now this is like simply there is no red flags, physical examination is normal, there is no blood in the stool, there is no weight loss, there is um, nothing is there. They don't have diarrhea, they don't have family history of inflammatory bowel disease, right? So now, whenever this is the cause, we call that thing as functional abdominal pain. And now, if you will go in more detail, guys, because there can be subclassified as, you can say, one thing is called as functional um, dyspepsia, okay. um, what happens, like, they have pain in the upper abdomen, or you can say we call it as irritable bowel syndrome, okay. So like they have alternating bowel movements, and one of the thing which I will tell you is abdominal migraine, okay. Now, what is abdominal migraine? Basically this is abdominal pain which is associated with anorexia, nausea, vomiting, and pallor, okay. So uh, now, one thing, guys, um, remember this thing that um, functional abdominal pain doesn't cause weight loss. Functional abdominal pain never wake up the child from sleep. So, functional abdominal pain, you can say, it doesn't give any signs or symptoms. This is very, very, very important thing. Okay. So simply, we on the history we rule out all these things. On the examination, we rule out all these things. And remember, functional abdominal pain is a diagnosis of exclusion, okay. So when you exclude all the things, we label them as functional abdominal pain, okay. So remember, guys, most of this functional abdominal pain are due to some psychosocial stresses, like, for example, it comes uh, before going to the school, right? So they have this pain, you can say, before, when they are going to school. So before that, they had this pain. So the thing is, what we can do is, like, of course, like, we do counseling of the parents, of the family, of the baby. Sometimes we give a trial of high fiber diet, okay, uh, as well as, uh, you can say lactose free diet, okay. So, like, these things can be tried, okay. So most of the time, we don't give them any medications. Okay, sometimes, we can give them, for example, if it is functional dyspepsia, we can give them um, like the acid reduction medications. Okay, or sometimes if it's a crampy type of pain, we can give them antispasmodic drugs. But most of the time, we don't give them any drugs. Like mostly, we counsel them and we reassure the parents that um, nothing to worry about. Okay, so reassure the parents about this thing, because most of these pains they resolve on itself. That doesn't cause much uh, problem, right? So this is how we go for what you can say chronic abdominal pain. And remember, guys, acute abdominal pain, most of the causes you can see are basically surgical problems rather than medical problems, right? So remember this thing. One of the thing, I did not start about diarrhea. I will discuss about diarrhea maybe in the next lecture, or maybe in this lecture. I'm not sure. Before closing this lecture down, one of the thing is abdominal mass. Okay, now we will not go of course, like when there is abdominal mass, so it is again some surgical type of problem. But few things I wanted to mention you. Um, in the newborns, okay, like these are some important clinical points you can remember. In the newborns, if there is a mass in abdomen, okay, like in the newborn I'm talking about, so 50% of abdominal masses are renal in origin. Okay, remember this thing. So um, now 50 of the percent of the abdominal masses, they originate from the kidneys. So basically what they are like they could be um, polycystic kidney disease. Okay, kidney disease. They could be hydronephrosis. They may have nephroblastoma. So it is also called as Wilms tumor. Okay, Wilms tumor. And now, what is this tumor, guys? This is a malignant tumor of um, kidney, which can present after the birth. So simply, whenever it is present, the Wilms tumor is present. So the treatment is simply surgical removal, followed by chemotherapy and radiotherapy. Okay, or it could be renal cell carcinoma. So Wilms tumor is carcinoma. Wilms tumor is a common type of thing. And rest of what you can say, the masses can arise from anything other than the kidney. For example, the masses can originate from the adrenal gland or the ovaries, or it could be any other mass like hernia. Okay, things like this. So this is like very very important thing, that 50% of the abdominal masses are renal in origin. Rest, guys, bleeding from the GIT is not so common. Okay, but whenever it is there, like the GIT bleeding. By the way, whenever there is GIT bleeding, we divide it into two main categories. One is called as upper GIT bleed, and one is called as lower GIT bleed. Now, again, like these topics, I will not go study. Like I'm not teaching you in too much detail, because you are going to study all these topics in surgery in detail, right? So, of course, like whenever there is GIT bleeding, we differentiate them in two main categories, like upper GIT bleeding, okay, and lower GIT bleeding. So of course, like upper GIT bleeding, there can be different causes like vomiting and blood and vomit, right, or hematemesis, we say. So there could be multiple reasons. Or lower GIT bleeding, there could be multiple reasons for that. For example, if we will talk about the lower GIT bleed, what can be the causes? It could be due to infections, diarrhea, in which there is bloody diarrhea, or it could be, you can say, like anything like malrotation, or volvulus, or volvulus, or you can say intussusception. I show you that red current jelly stools, right? So intussusception can be there, or for example, there could be anal fissures. Okay, like the child when they have constipation. And by the way, anal fissures are the most common cause of chronic lower GIT bleed in children. Okay, so anything can be there, like uh, hinox purpura can be there, hemolytic uremic syndrome can be there, inflammatory bowel diseases can be there, you can say allergies can be there, like cow milk protein allergy, I talk about that, or polyps can be there. Like if it's adults, like more than 6 years of age, cancers can be there. But in children, the cancers are not so common, so they are rare. So that's why they are not the common thing. So simply, whenever there is GIT bleed, guys, again, the important thing to remember over here is what, always check the hemodynamic status. You will take the blood pressure, you are going to take the pulse, and you are going to check the hydration status. And simply, we go for examination, we look for all the causes, we can do CBC, ESR, CRP, stool examination. You can do the rectal examination for this one, physical examination, to see for any anal tags or fissures or things like this, right? So simply on the cause, of course, we will go for such investigations. You can do urine analysis for HSP or HUS, okay, CBC, ESR, CRP. Yes, one of the things is coagulopathies, coagulopathies. When the patient, they have some bleeding disorder, so they can present. So of course, like always check the hemodynamic status and clinical dehydration status. And most of these, if severe surgical surgeries, you can say, are performed uh, in most of the cases, right? Most of the cases, like this one, interception, and of this one, surgeries performed are surgeries for surgical causes, okay, um, or if there is any medical causes, treat that. So that's all, guys, for this lecture. And in the next lecture, what we are going to study is the diarrhea thing, because like in this lecture we did not talk about diarrhea. So in the next lecture, what we will do, we are going to study, talk about diarrhea or different causes which can cause diarrhea in children. And after that, of course, like or GIT conditions will be done. Okay, so the fluid management of the dehydration, we already talk about that, in one of the lecture, how much give and how much we should give and things like this. So in the next lecture, we are going to talk about diarrhea, and while talking about that, we will be covering the diseases like celiac disease and IBDs, right? So thank you so much, guys, for listening, and I will see you in the next lecture.